Hello, everyone, and welcome to the webinar, The Effect of Public Health Policies on Stigma and Innovations in HIV Case Management Nursing. My name is Rachel McLean, and I'll be your webinar moderator today. And so before I hand it over to our presenter, Linda, I just have a few housekeeping items to go over. So this webinar is being offered by the Canadian Public Health Association, and our office is located on the original unceded territory of the Algonquin Anishinaabe people. They have been the guardians of this land for millennia, and CPHA is very grateful for the example their stewardship provides. So as some of you may be aware, this webinar is being provided as part of a webinar series that we've been hosting over the last several months, focused on the reduction of stigma associated with sexually transmitted and bloodborne infections. More information on this webinar series can be found on CPHA's website at the link provided on the screen. And you can also connect with me directly if you'd like further information on the webinar series. I will be providing my email address at the end of this session. So hopefully you can all hear me through either a headset or the speakers on your computer. And just due to the number of participants that we have joining today, we have disabled everyone's microphone. So while we will certainly have some time at the end of the session for questions, we simply ask that you use the chat box to the right of your screen to pose your questions to our presenter today. And then lastly, before we begin, just a quick note to let you know that today's session will be recorded and it will be made available on CPHA's YouTube channel in the coming weeks. So today we are going to hear from Linda Jorgensen, and I'm going to provide you with a brief bio for Linda and then hand it over to her for her presentation. So Linda Jorgensen is a registered nurse and faculty member with the School of Nursing at York University. She is currently completing a doctoral degree at the University of Ottawa. Her fields of study are community health nursing and the socio-political context of health. As a former public health nurse, she has lived and worked in Canada, Africa, and the Middle East, and brings a local and global perspective, as well as a social justice and critical theory lens to her research and teaching. She is particularly interested in the concepts of meaningful engagement, decolonization, and collaborative practice, and helping develop a more inclusive and comprehensive approach to infectious diseases management in public health care with people affected by HIV and tuberculosis. So with that, I will hand it over to Linda.
Okay, thank you very much, Rachel, for that introduction. I'm just going to set up my screen here. All right. Yes, so thank you very much for inviting me to participate in this webinar series. Very timely to be addressing stigma. And yes, my presentation today is really about the effect of public health policies on stigma and innovations in case management nursing. And it's based on the results of my doctoral thesis, which started out of my own experiences reflecting on my time in the field of HIV and community health nursing. And my own work in HIV is actually spans almost the length of the epidemic in Canada. I started originally in the 1990s I volunteered as an HIV/AIDS educator for a pediatric unit in Kingston, Ontario. At a time that was the time when there was no treatment available for HIV, and really compassionate care was the main tool available. I later worked in Kingston with the late Rafi Ballion and helped try to set up one of the first outreach HIV testing and hepatitis B vaccination services. And I did my own research on the meaning and function of illicit drug use for women at a time that that would help promote the idea of comprehensive care and establish a street health unit in Kingston. I later moved overseas, and I lived between 1997 and 2010 in different places in Africa and the Middle East. And I was working with the US State Department at a time when PEPFAR was rolled out to try and get treatment available to people living in Africa. And I also, at that time, was when Thabo Mbeki was elected president for the first time in South Africa, and that I was participated in a conference with nurses across the continent to start to look at how we might develop new social messages that address different ideas about the nature and even the existence of HIV at that time. So mainly what all this was to say is that what I learned is, first of all, importance of public health care. And the also was that there are a variety of different shapes that a public health response can take. So when I returned to Canada in 2010, I had the privilege of working in Ottawa Public Health. I was hired to work as a case management nurse in HIV, and I see there's some people logged in from Ottawa Public Health, so I will shout out to them. And I that in that job I was responsible for meeting people newly diagnosed with HIV that fell under this jurisdiction. And the ideas in my thesis that I returned back to school grew out of all these experiences. It's in a way to look at, after 25 years of seeing different ways of how we approach the HIV responses, try to what can we do to develop the quality of care for people living with HIV at this point in Canada. So it was both with hope and some hesitancy that I received the news of the report from the Canadian Foundation of AIDS Research that there might be an end to HIV in Canada in 5 years, and the CanFAR proposed 5 solutions, 5 steps to get there, and that is to first we need to raise awareness. We also need to look at how to continue to scale up ideas about messages about U equals U, undetectable equals untransmittable, and make more available PrEP and PEP, and services for harm reduction. And the last strategy is the one that actually my work focuses most on, is how can we address structural barriers to health and wellness, such as poverty, mental health, addictions, racism, and other forms of discrimination through public health work that could put people at risk of HIV. So this report's actually titled A Time to Act. And I think what I'm excited about most today is actually taking the time to engage in dialogue with all of you from across Canada about what does it mean to end HIV? What would success look like? And it's quite fitting that today, actually March 21st, is actually the UN's International Day for the Elimination of Racial Discrimination. And so I think it's very fitting to look at the concern raised by Winston Husbands, a senior scientist who was involved in writing the report, but also raised the question, ending the epidemic for whom? So I think we have to, what I'm really excited about looking at is what are the indicators of success? How is health and success, the definition of health and success used in public health, actually helping to address or maybe contributing to ideas about structural stigma, those structural barriers that we're concerned about? And that is, how might our institutional policies be addressing or constraining opportunities and resources and well-being of the stigmatized? And I think there's been a long time a call to action to look at the connections between infections and inequalities, and it's particularly probably timely now, as only 2 weeks ago, Prime Minister apologized to the Inuit for the mismanagement of tuberculosis in the north. So I'm really excited about this opportunity for all of us to sit together and collectively have a discussion about how we might look at what we can do within public health to promote more quality of care and form more effective partnerships with the people who are most affected by HIV and other infectious disease management approaches as well. So to take it, before scaling up any further, is to pause and examine maybe what are some of the reasons for the shortcomings in the current public health response to HIV and AIDS. So I'd like to now just show you a little bit about some of the results of my study that I did as my for my doctoral work. And really, we're all familiar with images like this in the media, or conceptualizations of infectious disease management as a war. The war on Ebola, the war on SARS, the war on HIV/AIDS. And so the real purpose of my work was to really understand.
Sorry, Linda.
Yes.
Sorry, I hate to interrupt. Do you mind just perhaps speaking a little bit louder? We just had a few concerns about the audio being on the lower end side.
Okay. I'll try. Can you hear me better now? I will talk louder. So I've got these noise canceling headphones on, so it's hard to hear myself. Okay. So the purpose of my work is really to understand how equating the management of infectious diseases war actually might be shaping our public health policy, nursing interventions used in public health, and the experiences of our clients with HIV. And just a little background, what we're seeing is that we've made great strides in with the advent of medical treatment in 1996 for helping reduce the spread of the virus, particularly containing the spread of the disease, and also more recently getting people onto antiretroviral medication quite soon. I think it's within the first 3 months after being diagnosed. But what we're still seeing is that even though we have these fabulous testing and treatment technologies, we're still seeing over 2,000 new infections annually. So the real issue in HIV case management is how we can better engage people in testing, treatment, and support services. And so Canada has signed on to a global initiative started with the United Nations, and one is the idea that the 90-90-90 strategy, that if every country is aims to have by 90% of people living with HIV diagnosed, and 90% of those diagnosed started on antiretroviral therapy, and 90% of those actually achieve viral suppression. That's where the idea that we can actually lower the pool of HIV, that the epidemic would be could be ended. It could be stopped, at least contained within small pockets. And if you see Canada's progress at the time of my study, we have made strides, in particularly in viral suppression of those who do get into specialized care. But where we're still struggling a bit is in the area between people learning their diagnosis and starting treatment. And that is actually the area where case management people work, at the idea of taking people newly diagnosed and engaging them in follow-up. Some of the barriers to engaging people in treatment that have been forth can be divided into medical issues as well as social and emotional issues. And some of the issues have been addressed medically with the advent of new types of testing and treatment, and especially PrEP and community-based PrEP. But some of the concerns are that maybe the emphasis on scaling up medical treatment and distribution of resources to that goal has been meant less strategies to address the social and emotional barriers in the HIV response. And when Canada actually reported back on its progress, a nationwide consultation, multi-stakeholders were involved, and the summary was that the 5 key challenges in actually achieving success in the epidemic based on the current models, that we still need to address stigma and discrimination, and that there's a limited inclusion still of people who feel marginalized in the epidemic, difficulty of our model in responding to issues as they emerge, and a lack of coordination across levels and jurisdictions, and some inconsistencies across health units. So what we're seeing is actually then is different ideas about what direction the HIV response should take. So epidemiology has been able to help identify the people most affected by HIV, and we know that they come mostly from populations with a history of marginalization due to stigma and discrimination. And while we look at some of the ones who are mostly affected and target our resources there, some of the groups that maybe don't count in terms of numbers also continue to feel like maybe there's some concerns that women at risk, trans women, people living in rural areas who have more difficulties accessing care may not be benefiting from that approach as much. And what the people from those communities are telling us when you look at their strategies is their concern is really about quality of life and establishing more involvement in the decision making about the direction of the HIV response, and issues around trust and confidentiality. And our federal strategy and public health model actually emphasizes more about vaccine development and the development of new testing and treatment technologies, and counseling people about the risks, and focus on behavior modification and distribution of condoms and clean needles and other paraphernalia to help support those goals, and also involvement in surveillance. And another approach that we're also that is shapes the response is an ethical legal approach which HELCO has been led on the forefront in addressing. Is that in Canada, if you test positive for HIV, you have an ethical legal obligation to disclose your status in situations where where people might be put at reasonable risk for contracting the virus. But what we're seeing is that in Canada, medical evidence isn't always used, and there's been a bigger commitment in the last 2 years uh, through the work of HELCO, and the federal government has signed on, but we haven't seen as many changes yet, and we still are among the top countries that with the most prosecutions and convictions for people for non-disclosure. And what we're seeing is that Ontario as a province is one of the highest rates of criminal prosecution and HIV status. And my study focused on the situation in Ontario. So every year, Ontario reports the most number of new cases of HIV. And we also report the highest number of new cases of prosecutions for non-disclosure. And the people most affected in Ontario tend to come from groups that with a for the African Caribbean men are particularly affected. So it's disproportionately affected in terms of the number of people who, of the different groups that are at risk for HIV and living with HIV. So in Ontario, at the same time, then we're seeing is the proliferation of anonymous test sites of people choosing then to learn their status in a place where they can where their name won't be requested or reported or recorded by public health. So I think one of the main problems, and that if we put this all together, the persistent number of new infections, the number of stakeholders with concerns about stigma and exclusion, and the evidence of avoidance of public health, that as a public health nurse, that I think that there's a real opportunity here that we need to critically reflect on how our own strategies, what the shortcomings are in our own strategies for how we might learn about those and to be able to better address the needs of people living with HIV. So that led to my research question, was to really take a look back at what are the policy and strategies used by case management nurses across Ontario to engage people at risk for living with HIV/AIDS in testing, treatment, and support services. And particularly, what can we learn from there? What can we build on that's working? And what kind of innovations exist across the province? And when I looked at the literature review, there was actually very few examples of studies done by or for nurses in case management in a public health. And the ones that did exist were done early on in the academic or internationally with nurses who lived overseas. One of the issues is that if you look at the graph, when I started plotting out when the studies were done and by who, if you look before the advent of antiretroviral medications in 1996 is when nurses were most visible and vocal, and the most publications about nurses' role, and that again is when compassion was the strategy. And as we later on, as medications became the focus, there's a lot in the last 10 years. There's actually a lot less studies or information about the work of nurses in public health. So we know that there's a variety of different responses, particularly to either a harm reduction approach or one that focuses on risk, but we have little information to support nurses' work in case management in public health. So with my research, I decided then to design a critical ethnography using a feminist lens, looking at the critical geography by David Sibley and the concepts in social theory about governmentality, since we're looking at how has case management's been organized, and then to look at what's working, what are examples of norms, what is the normal practice and policy available to in case management nurses, and what are some of the differences across the province. And the idea is that we look at what is so that we can try to see what could be. And I was fortunate that there was a great response and interest across the province in nurses and management and case management. And of the 6 different regions where we have public health units, and I was able to do field work in each one, at least one health unit represented in each region, and there was 14 public health units in total and 22 nurses that participated in the study. And if you're listening today, I also want to thank you very much for your participation and the management teams that welcomed me into the health units and shared their stories. So in the summer of 2016, I traveled across the province, airplanes, trains, and automobiles, and visited each of these sites, and was given a tour and shadowed nurses and talked and did interviews about their work, as well as collected the different kinds of policies and forms and educational materials that are used in practice. And these were all analyzed individually and then together to form an overall profile of what is happening, what's the state of HIV case management, and what can we learn from it today. So one of the main findings first was the demographics of the nurses that are involved. It's usually about 1 or 2 nurses per each health unit, although that does vary a little bit. I think the main thing is that there is little diversity among nurses, and nurses themselves said that. I'm just going to quote one participant who said, and you know, it is an issue that we're all white women that work here. There's no men, there's little ethnic diversity, and there's no people who identify as men of sex with men who work here. And I think ideally that's what some of our clients would like to see. It just seems that that's what we get for applicants. And in fact, what we see is that the nurses who are involved in HIV case management in a health unit are among the most experienced nurses in that unit, most of them having over 16 years of experience as a nurse. And nurses say that that's needed to, that the experience is needed to be able to manage some of the challenges of living with HIV in Ontario. So when I did a thematic analysis of the interviews and the policies, 3 themes emerged about how case management, about the experience of nurses in case management that's reorientated to the work around the treatment cascade, about following the steps of the treatment cascade. And that one is that there's a little bit of a concern with avoiding trouble and when encouraging people to conform to the steps of the cascade. And the second theme was that nurses described their work as living with a client for a while and efforts to collaborate with clients. And also a third theme is that the experience of what's called the whole dance we do is nurses trying to balance the dual obligations between protecting the public and supporting individuals in their unique needs. So I'm just going to start with share with you examples from the analysis of the policies first. And when we actually look at what is a definition of a case used for case management, it is based on an epidemiological definition, a positive lab result. And then case management itself is based on a few policies, mostly biomedical policies, the infectious disease protocol, the sexual health and transmitted infections protocol, and primarily organized around the Health Promotion and Protection Act. And the purpose is to follow up on the positive lab reports. So when you look in the policies, the idea is that the role of the nurse then is to investigate each report of HIV in order to ensure that the client, and you can see how they follow the treatment cascade, is properly informed of their infection, connected to clinical support services, and aware of the actions to prevent the minimization of the spread of HIV infection. And in fact, there's clear steps that we're seeing across Ontario in nurses' efforts to engage people in the treatment cascade. It starts by always verifying the lab result is indeed a true positive, contacting the testing clinician offices to see how much follow-up has been done, contacting the person with HIV and providing counseling, and also partner notification. And so you can see how the steps of case management in the official policies very much reflect the treatment cascade, even though the treatment cascade in the 90-90-90 strategies aren't referenced anywhere in the policies. It's implicit in nurses' work. But also implicit in nurses' work is how much the emphasis on engaging people in compliance with the cascade has shaped some of the dialogue in their practice and overshadowed some of the counseling they do, and that there's a real emphasis in describing to clients the difference between public health law and criminal law. And this is one of the quotes that I'm just going to share with you because it is the main finding. that according to criminal law, there are things that if you don't follow, you could be charged. And public health law is based on the Health Promotion and Protection Act. The difference would be that the criminal law might say, that you don't have to disclose if your viral load is low and you're using condoms. But we do feel strongly in public health that you should always disclose and use condoms and take the risk down to as low as possible. And obviously that's very general. In our pamphlets, we do talk though about the medical officer of health does have the power to section people for not following those directions. So if you were having sex and not disclosing to anybody, you could get in trouble on two fronts, really, criminal and public health law. Yeah, so I say there is a difference. And one thing I'm going to tell you about today is what you have to do legally to avoid criminal charges, and the other is what we would like to see you do. So in a sense, this approach that in the policies is focused on the disease. It's a biomedical approach, and as well as on surveillance, and also the duty to disclose. So in case management, the steps very much follow the idea of counseling people about their risk, counseling people at duty to disclose, and ensuring people are linked to testing and treatment. And the meaning of this engagement then becomes a sort of mandatory follow-up with compliance on the treatment cascade. So how you can see a bit in this model how the definition of HIV as a war is translated into this idea of mandatory engagement and treatment cascade. In the end, the success in the epidemic in HIV care is that you achieve viral suppression. It's an individual biomedical marker that's used as the indicator of health. And in this model, then, by virtue of carrying the virus, people with HIV are considered threats to the public until and engaged on this in surveillance to be able to monitor at which stage we should, in public health, focus our interventions in order to help them continue along this pathway. And you can see when I interviewed nurses about the steps used, that they did try to ensure that people were notified of their results. That was a main first step. And the second is to counsel and ensure people are linked to treatment. And then as they continue on, that if they were to test positive again, to recounsel about disclosure, the need to disclose and continue getting treatment for any other STIs. And in fact, when I looked at how public health units were organized, there were some differences, but in most places across Ontario, there's a common structure that also reflects this sort of viral-centric approach and the steps of the engagement in the treatment cascade. It's starting from the public entering sort of at that very front line into a public health unit, which is usually a clinic area where they're sorted by an administrator and they can go in for testing. And the next section of a public health unit is often where the so-called frontline providers work, and those are nurses in case management as well as other health promotion and inspection teams. And in case management, the nurses are often organized by disease, chlamydia case management, HIV case management, syphilis case management. And next to nurses, and often in their own space, is the immediate managers, and there's a lot of autonomy between the two in Ontario. And then often in a separate floor, often even in a separate building or a separate city, are the associate medical officers of health, who are responsible for decision making in cases when people aren't complying with the treatment cascade. And in fact, most of the reporting is in a linear one-way fashion, that as long as things are working, the case management continues as it is and with autonomy, but nurses are expected to report anybody who has any problems or unwilling or unable to achieve the steps of the cascade. And then the medical officer of health decides on the strategies that usually using a ethical framework of the least coercive, most effective approach, which can be anything from more intensive counseling to a section, which means people will report to the health unit for life to check in on their ability to comply with risks and non-disclosure. So although it's been argued that the treatment cascade is not meant to be linear and it's dynamic and it requires viewing people as individuals who are in a holistic approach to health and that considers the determinants of health, in actuality, what clients tell us and other researchers say is that when using the treatment cascade and the goal is actually to eliminate the virus, the effect is a compartmentalized care, a focus not so much on the client but the disease parts of their body that a doctor can monitor, and an impersonal form of care that actually exacerbates the history of these groups of feeling abandoned in the epidemic. When I interviewed nurses, there was a clear that the nurses were able to follow along with the steps and do their duties to report the information on their surveillance tools used in public health. But when I asked nurses what the definition of success was in HIV case management, across the board, they all said that a client feels supported, regardless of whether they're able or willing to engage in treatment at the time. And so then I started to look at what kind of care was tied to that goal. And this kind of care actually exists at the very sort of is more invisible in the policies. You don't see it in there, but there is thematically across the province, nurses follow these 5 steps when they at the intimate relations between client and nurse when they do meet for case management. And that is that their first step is to actually start with the client, learning the client's story, with their background with HIV, and starting where the client is at in a phone call with open questions, and counseling begins with a conversation about what is most important to the client. And in some cases, that's counseling about nutrition, talking about the experiences of coming out as being gay for the first time. Sometimes it's about financial issues. Nurses are also involved in hearing and helping people address their concerns to access to care in rural areas, mental illness and the challenges of staying engaged in HIV care, and homelessness, those just to name a few. But I think what's most telling is that those discussions and that data is lost because it's not being documented so much anymore. And there's lots of literature to show studies that have examined how nursing practices and particularly their documentation has changed as a result of both the biomedical security approach, that with the risk of their charts being subpoenaed, where more health units are not documenting all the information about some of the concerns and stories that we're learning about, that we could be developing programs around if we had that information. And in this goal, well, the goal in the biomedical and biosecurity approach is one fixed biomedical marker and achieving undetectable viral load. In nurses' work, it's more variable. The goal is actually indicators of how well people are coping, and that depends on the context of care. So that leads to the third theme, is that nurses describe the engagement in nursing practice as not necessarily as treatment as prevention, although it does exist. They move back and forth, and what's found in the literature in other cases of nursing is called the sliding trombone effect, between protecting the public and following the medical orders, but is also at the same time practicing at a full scope of practice in nursing, which accompanies the emotional and social concerns. And then what nurses say success is that I find if you show people that you care about them, the first thing shouldn't be you've got to get treatment. The first thing should be talking to them about how they can make it through this difficult time. But it's hard. You're always weighing out what's important for the individual with preventing transmission to the public. And sometimes you feel you might be shortchanging one over the other. And this leads to the most interesting part of the findings, because these are the areas where the struggle is, where I think we can learn about where there's a lot of great ideas about where we can look at where with more research and more dialogue and more data, we might be able to improve on our response to HIV. And the medical model has brought us far, but perhaps in some of these areas where there's tensions between clients, nurses, and and the response to public health is where we have ability right now to do some changes and reflection that could take us to the next level in achieving success in HIV. And one of the main areas is around the limits and contact tracing is how we define that. We don't have very much evidence at this point about what's the best method to be who notifies and how far to trace back. Nurses also suggest that there's very little evidence or policies to guide them in disclosure counseling, and they're not sure about the role of that in HIV. They say the people with the most challenges are the ones that have the least options other than a section right now, and that the timelines that we put on people about what point they need to achieve before a section will be issued tend to be arbitrary and decided across the province, not with evidence as well. So one of the other ideas is that nurses feel that they do outreach and they work with other colleagues, but often this part of their work is limited depending because it doesn't fit in with the indicators on the official model or the treatment cascade. When there's time constraints, it's one of the first things to go. And so in terms of engagement, what we're seeing across the province is that our partnerships tend to be one way and limited as well. It's in case management nursing and public health from the point of care, working with other stakeholders. So this is very interesting. I love this model. A new strategy was put out by the Ontario Advisory Committee on HIV/AIDS and about trying to achieve a strategy until 2026, and they identified all the different stakeholders and put them in a cluster. Ideally, this is that we would all be working together in the HIV response. So what I did was based on the interview data, is I traced and attached what the nature of the relationships with those groups are, and it shows you that our current partners, if you look on the example on the left, is mostly one way. It usually involves nurses seeking and treating, again in compliance with to try and reach people to engage them on the treatment cascade. And what's happening, if you look on the right, is there is actually a number of stakeholders that there is no connection to at all. And I think one of the main ones is for case management nurses that came out is they find they have little access to other nurses in case management because the lines of communication are vertical through a health unit and not horizontal across the province. There's few mechanisms to meet and discuss how to address issues in care. And there's very little links to research and knowledge exchange. And that's where hopefully my program research will help come in. And there's also, you can see with some community stakeholder groups, particularly programs that are working with the groups who are most affected or designed from coalitions of groups to improve the quality of care. We have few connections with those groups as well as some of the federal initiatives, particularly for Indigenous people. There's a lot of jurisdictional confusion about how to best manage care, and there's little interaction from the point of care nurses at this point based on the current model, and little time for that outreach built in. And just to look at, there was another study that social network analysis that was done in a large health unit in Ontario, and they also found the same, that the lines of communication were usually one way from the point of care upwards to the medical officer help, and very little information exchange flowing through a health unit. And their recommendations were that identifying local coordinators, and mainly practitioners or clinical staff, and enhancing their connections to professional information sources could be an organizational intervention that would reduce the hierarchical flow of information and facilitate the adoption of evidence-informed decision-making as a sustained organizational change. So I think the main thing that I suppose the takeaway is that this study shows it is an ethnography, and it's not showing that necessarily one model of care is more valuable than another. What it does do is provide evidence that how the current model using a single indicator may be limiting the kinds of services that we develop, and particularly for the people that have the most challenges in able to engage in care along the treatment cascade. And what's interesting is that when we look at the idea of the treatment cascade that was developed out of UNAIDS, it's only one model at the global level that Canada has signed on for. In fact, there are two sections of the UN that are involved in HIV care, and the other is the UNDP. It's the HIV development project, and they're responsible for integrating HIV into Sustainable Development Goals. And Mandeep Dhaliwal is the head of that unit, and this quote is from her about the direction that we need to in fact achieve success in HIV is to make advances on the health of vulnerable groups. There is a need for a greater effort to reach those who are left furthest behind, for deeper cooperation across all sectors and levels, and for renewed focus on addressing the root causes of economic, social, and environmental determinants of health. And even in the Canadian Public Health Association, there is a debate about whether we should move towards more primary care to achieve our goals in HIV or the social determinants of health. And their views is that the public health approaches that focus on equity and cultural safety are needed to contribute to the quality of care. And another quote that public health is not simply an endless effort to prevent illness one person at a time. So if you look at the Sustainable Development Goals that Canada also has signed on to, but it seems that we haven't embraced these yet in our own Public Health Agency of Canada, or the strategies that are circulating federally and provincially, is that goal number 3 is good health, and it's couched within, it's interconnected to a broad social conditions of health. And what's wonderful about these goals is that if we're looking to develop more emotional or social indicators of success to attach them onto that treatment cascade, each one of these goals comes with already well designed and with experts and collaboration across all of the world on what those indicators might be that we could draw from. So finally, thank you for your patience. And so what are the implications? So based on my findings, again, it's not that I can say there's no evidence to support one way to go versus another, but these are what are the ideas that come from our reflecting on where we're at in our own approach. And we've been able to achieve through a medical lens that maybe that medical lens doesn't have the tools to include social theory or some of the other approaches that might be needed. And so I think one of the issues that is being where there's momentum both globally and in Canada is for a more stakeholder-centric model of care, and one with community development has additional indicators in the model. And if we look at what those indicators of success might be, this is a quote from one of the nurses in the studies that I think it's just when everyone leaves the process respected and everyone feels their needs have been met on both sides too, not just the client, but as far as the team and the services, they work together, that's success. So if there is a political will to try to look at what we might do within public health to make our own response to HIV more robust, it might be to focus on capacity development to support case management nurses to develop this parts of their practice. And that is that it starts with a commitment to a greater mutual engagement and collaborative practice both within and across health units and jurisdictions. And we might also look at how we can foster the expansion of nursing network. First, so they can communicate with each other and with academics and other stakeholder groups to start to develop collaboratively ideas for how to address some of the tensions in care, because I think those are the places with the most potential to make a difference. And by working collaboratively, we can jointly develop policies and plans to address stigma. And I think it's hopeful that Canadian Public Health Association just released an example of a policy that's not disease-centric or virus-centric, but they just the idea of an anti-racism policy. And together, actually, my work with Rachel is looking at how we can develop maybe an anti-stigma policy for public health. The other is that to promote dialogue with partners about how to address some of the ambiguities in HIV response and forge partnerships for practice-based research, for research to develop that supports the practice of public health practitioners and evidence-based decision making. And I think finally, based on the lack of diversity, is to increase the efforts to actualize affirmative action in recruitment and hiring at all levels of public health. I think that if you see that it's the diversity in the model that can help us design a more robust a model of public health with more comprehensive indicators. From a nursing innovations that are already happening along that lines is there one of the policies already has addressed that not only the roles of nurses in the policy, but has tried to make transparent the roles of the other stakeholders. What are the role of the associate medical officer of health and the managers in the treatment cascade? Those need to be more clearly defined. And since they are missing currently in policies, this is a great place to start for how we can renegotiate some of the collaborative style of case management and in the HIV response, if that's of interest. And then also looking at then how we can create more space for accommodating people with complex needs, so that in the space between those who can easily or more willing or able, what can we do to provide services or develop services for people who are having the most challenges, so that the Section 22 isn't the only or one of the few resources available to public health in order to support those people. And there's a lot of effort to be done to redesign forms. And I think if the end of criminal, the issues around disclosure and prosecutions is limited and supported with more medical evidence, that we could start using the stories from the point of care to help develop some ideas for defining new strategies to support people with the most challenges. And also there is need to develop networks for sharing evidence across jurisdictions and across health units, and not only on medical and treatment technologies, but engaging people in outreach and partnerships to form issues-based coalitions around social determinants of health, like racism and addressing homophobia. And there's already some work being done on this front. For instance, in TB, there's one of the health units is led by an associate medical officer for health, is working with health promotion officers, with researchers and nurses to look at developing research on the issues of stigma in TB care, as an example. There are also examples in one health unit of epidemiologists working closely with the nurses at the point of care to tie strategies for research and at the local level that can facilitate development of projects. But that's only in one of the health units that I came across of all 14. So there's lots of places where we can engage more in multidisciplinary efforts at the point of care, both within health unit teams and across the province and with all our stakeholders, that hopefully we can move from the phase of a sole strategy that looks at how to continue people along a one linear pathway to what's considered public health, to maybe looking at in Canada how we can better support people that are living longer and trying to achieve a better quality of life with HIV care. And this is just to show that what an example of an issue-based coalition. And again, I think we have achieved great success through the biomedical model, but I think at this point, to be responsive in the HIV response, we might look at how we can better balance some of the lenses and research from social theory and people-centered approaches to maybe take us to the next step. And I'll leave it at that. Thank you very much for listening, and I'm happy to entertain any questions you might have.
So thank you, Linda, so much for that very informative presentation. It's certainly exciting to think about kind of integrating some of these stigma reduction strategies more systematically into public health practice. So as Linda mentioned, at this time, please use the chat box to ask any questions to Linda. And then just a note that these questions will be shared with all of today's webinar participants. So we do have a comment here from Amanda, so I'll just read that out as other folks are taking some time to pose their questions. So we have many public health units have policies and procedures based on the former assumption that HIV is always infectious. Given the conclusive evidence of TASP, treatment as prevention, i.e. HIV is non-infectious when viral load is less than 200 copies per milliliter, how have public health units adapted their policies and procedures? For example, contact notification not necessary if HIV positive client is virally suppressed, disclosure not relevant from a public health perspective, i.e. regarding transmission, if condition is non-infectious. So Linda, I'll let you respond to that.
Yeah, I think that's a great question, my data was collected in 2016, and the U equals U movement has made great strides since then. And so at the time, it wasn't discussed as much, although treatment as prevention was certainly a strategy, and you can see that across the board in terms of that's the primary strategy in the official policies. So I think what I really I think what my work I hope shows is that it's that when we look at interventions, we don't just start with the idea of scaling up, but first look within public health to see, yes, exactly what you're saying is how might we then, knowing this, look at what we're doing in our own practice, how might it affect it, and then working with collaborators in academics and also across stakeholders about trying to develop to get the evidence, to look at the literature, work together to come up with a way to redesign how we to respond. And that was one of the 5 key strategies, to change our own practices and not to better reflect the state of the literature. And I think the other thing is, though, treatment as prevention is one thing, but I think all those things again have to be couched with ideas about what is quality of health as indicators. Again, U equals U is important for helping um, and helping to prevent the idea, to challenge the idea of people as threats to the public. But again, it's one biomedical marker as success. And what else can we work with with the people affected by HIV? What are other? I would challenge us to look at to develop other indicators of success, so that we don't end the response or HIV care prematurely, as Winston Husband was concerned about, knowing that people are still living with the virus and need support in other ways. So thank you for that question.
Thanks, Linda, for your response. I don't see any other questions at this time. There is one question about will the recording or presentation be emailed or available online? So certainly you'll receive an email from myself tomorrow with the presentation, perhaps tomorrow or in the next few days with the presentation, the PDF slides. And the recording will be made available on CPHA's YouTube channel in the coming weeks. And so I'll just take this time to once again thank Linda and for all of you for participating in today's session. And we do invite you to register for our next webinar, which is focused on HIV/AIDS related stigma among gay, bisexual, and other men who have sex with men. And it's going to be held on April 11th from 1 to 2 Eastern Time. And so you can register using the link on your screen. And then in terms of, we do ask that you take a few minutes to complete a post-webinar evaluation survey. This will just really help CPHA as well as Linda improve future presentations. As I mentioned, the recording will be available on CPHA's YouTube channel, so the link is there. If you're interested in learning any more about CPHA's work around reducing stigma related to STIs, you can access our website. And then for any questions for either myself or Linda, you can email me and I'll make sure those questions do get to Linda. So with that, I see there's another question from Esther. So Linda, I'll hand it back over to you. Has the study looked at partnerships with other AIDS service organizations to share the public health policies and why they are being implemented?
I'm not sure, but to share the public health policies. I did look at, as I said, I did try to include in the interview questions to get a sense of who are the people that nurses are connected to and what's the nature of the relationship and what kinds of information is shared. And and as I mentioned, there were some examples at different health units of different forms of relationships, but for the most part, those relationships were one way. It was often to help find a client or but although nurses really did express an interest in trying to do more work collaboratively to look at trying to address some of the issues and make care more seamless, those were often seen in the end in time management because they didn't necessarily fit the treatment cascade. And maybe I guess that needs to be an area that we need to look at is what kind of research could better support nurses as they engage with partnerships. And in fact, my own work, a spin-off of this study, is to look again at the issues of how TB is managed in the North, is to look at the meaning of engagement in care in the models that we're using for TB management, because we know that our Inuit partners are looking for collaborative approaches that are both epidemiologically sound but also culturally sensitive. And so I think that it's, again, that's another area for critical reflection and for future work going forward. So thank you, Esther, for that question. I think the forming the partnerships is the core of my own research and how we can build that into a new model of infectious disease management that maybe isn't war, but also is maybe a more of a collaborative approach, because I think that's the point we might be at this point as people, as we're seeing some of the shortcomings in that having all these great medical treatments that we can they're more likely to be sustainable if we work more collaboratively and have more diversity in looking at evaluation frameworks that account for diversity in what success and health is defined in.
Thanks, Esther, and for that question, and certainly thanks, Linda, for that response. I don't see any other questions, so I think at this time we can close the webinar. Thanks again for everyone on the line for participating and listening to this very informative presentation. As I said, the recording will be made available, and you can definitely contact me if you have any questions, either about CPHA's webinar series or some questions that I can forward on to Linda. Thanks, everyone, and have a great day.
Thank you, everyone. I'm happy to take questions anytime as well. You have my email address. Thank you, Rachel.